I explain monoclonal antibodies to patients by talking about the synergy and their immune system. I think with patients who have a diagnosis of cancer, they're disappointed that in ways that their body has let them down. But when you talk about monoclonal antibodies to a patient, explaining that it's their immune system that's also helping them overcome the plasma cells in their cancer. So I don't have a specific analogy, but I also like to draw pictures for patients of that specific cell, show them the target on the surface of the cell and how the monoclonal antibody attaches to it and how it works for the patient.
So generally, I start off and explain that actually it's very simple, that monoclonal antibodies help to enhance or stimulate the immune system so the patient's own immune system can fight their cancer cells. Also, I can use an analogy in using the key in the lock, so that we use the key and it unlocks the immune system for the patient to attack and fight and eliminate their cancer cells, their myeloma cells.
Most patients, when they come in for a cancer treatment, are expecting traditional chemotherapy. So it's kind of fun and exciting to explain to them what is the difference between a targeted therapy or a monoclonal antibody therapy as versus chemotherapy. So I use an analogy like laser therapy and a shotgun. So a shotgun, you're going to get a lot of scatter, a lot of damage done, both to the cancer but also to the normal cells as well. When we're talking about a targeted therapy or a monoclonal antibody therapy, I describe that more as a laser therapy directed at what causes that cancer cell to be abnormal. So the side effect profile, there still is some side effects, but they're very different, and they don't have the devastating effects sometimes that chemotherapy has. When we're talking about change in therapy, sometimes patients wonder why they go from a 3-therapy regimen or a 2-therapy regimen down to a 1-therapy regimen. And there's different reasons for that. So we always explain the rationale from that if they've had a previous backbone therapy. Sometimes we'll be adding that 3rd drug to it instead of taking it away. So it depends upon the situation and that patient's previous history of drugs, how their performance status is at that time, if they could tolerate certain drugs. And so it depends upon the patient and how we explain that as to what's going on with them.
So how do you explain treatment regimens for our patients, whether it's a single therapy, a doublet, or a triplet? It is a multifactorial decision that their physician will make a decision on, and this is based upon a patient's performance status, their age, whether a patient has any comorbidities, renal insufficiency, cardiac issues, lung issues. And so, again, all of these factors come into the decision-making process on with a patient's, how much of a type of a treatment the patient will receive. Generally, I will tell you that we do use a combination therapy because that is the key for overcoming drug resistance and in looking at better responses for our patients. You know, multiple myeloma is a heterogeneous disease. It's really not a one-size-fits-all treatment regimen.
How I talk to a patient about changing therapy is it's very common to use multi-drug regimens. And so we talk about the fact that you're building on that response for them by gaining that synergy with these multi-drugs, less side effects when you use them. Patients frequently have a question about, well, if this isn't working for me, how is adding this 3rd drug or this 4th drug going to make this better? And so you have to explain to them that these drugs all work in different ways. They hit different targets, and even though one of these drugs may stop working for you, when you add an additional, such as a monoclonal antibody, it still can overcome that relapse that we're seeing. The additional drugs make the other drugs work better.